I think this is the first day, first session of the main conference. So we welcome each other, everybody, we and you. So let's hope for the best that this conference, whole of the conference and this session goes well. So that there are strictly 6 minutes because this is a competitive session. If you don't wish that your marks should be cut, finish it in 6 minutes. So otherwise, after 6 minutes, it will close this thing. And it may have adverse effect on your marking, right? Because we have 85 minutes, and if everybody comes, for 82 minutes will be speakers will be speaking. So 3 minutes exchange of these speakers and everything, we are very short of time. So we'll try to finish in time because the next speakers and session people will be coming. So those who have not uploaded their presentation, they should do it immediately. So we'll call, we have been told by the scientific committee that we should be going exactly what they have, the papers they have given us, right? So if somebody is not coming in time, then at the end, if time permits, he will be taken up, otherwise we'll be sorry for him. So I request the first person, has he, Dr. Nivesh Gupta. Rohit Agarwal is, no, second one is Aditi Gupta. Yeah. According to our list, she is Aditi Gupta. We are going according to our list. This is given by scientific committee. So Dr. Nivesh Gupta is not there. So Dr. Aditi Gupta is there. Please be on the dais. So Dr. Aditi Gupta is speaking on intercalary membrane break and detachment causes intrachoroidal cavitation in macular coloboma. I think still half a minute is there. Okay. Yeah, you can start. Thank you.
Good morning, everybody. My presentation topic is intercalary membrane break and detachment causes intrachoroidal cavitation in macular coloboma. No financial disclosures. So macular coloboma is a rare, unilateral or bilateral, pigmented or non-pigmented, non-syndromic developmental defect of the eye located at the macula, characterized by well-circumscribed, oval or rounded, atrophic lesions of varying size presenting rudimentary or absent retina, choroid, and sclera, leading to the decreased vision and sometimes other symptoms such as strabismus. It occurs due to incomplete arcuate bundle differentiation along the horizontal raphe during embryonic development or may result from intrauterine infections such as rubella, measles, or even Toxoplasma gondii. Here are a few images of different types of macular coloboma which have been seen in the literatures. Intrachoroidal cavitation, now we come to as a structural features which is seen on OCT and is characterized by presence of a hyperreflective area between the unaltered RP and scleral boundary. It can either be peripapillary or macular in location. The pathological myopia is generally located with, associated with ICC, more commonly at the peripapillary location. So macular ICC associated with macular coloboma is quite a rare finding. There are two studies, one with Schoberger and Agarwal published 2 cases of grade 3 NCMD with macular ICC. Here both the patients were associated with posterior cephaloma and visual acuity was in the range of 2040 to 2060. There's another study where Markin et al. Demonstrated ICC due to the detachment of intercalary membrane in a case of iridoretinocorneal fundal coloboma. But no classification system is really given in the imaging of macular coloboma in the literature till date. So in this study, we aimed to diagnose and understand the pathogenesis of ICC in macular coloboma using multimodal imaging. We took a retrospective image analysis with patients diagnosed with macular coloboma between 2017 and 2021, whose color fundus photography, OCT, and multicolor imaging was done. So basically, on the OCT, we saw that there were 3 particular features which we were seeing, either whether it was conforming or non-conforming type of macular coloboma, the presence or absence of ICC, and the presence or absence of break in the intercalary membrane. In the conforming type, the intercalary membrane or thin retina conforms to the excavation of coloboma, while in the non-conforming type, there's a separation between the intercalary membrane and the base of maculocoloboma. ICC was identified on the raster volumes OCT scan by presence of a hyperreflective space beneath the unaltered RPE. On the on-fast multicolor image, two features were identified. One was the dark hyperreflective areas abutting the margin of macular coloboma, which is suggestive of an ICC, and the second was the presence of orange-colored boundaries surrounding the ICC. In the results, we took total 16 eyes of 11 patients who were already diagnosed with macular coloboma. Their ages were from 12 years to 58 years. Unilateral involvement was seen in 6 patients, while 5 patients had bilateral involvement. On the OCT, the conforming type of macular coloboma was seen in 9 eyes, while the non-conforming variant was noted in 7 eyes. Macular ICC was noted in 5 eyes of the 16 eyes. In all the 5 eyes of ICC, there was break in the intercalary membrane. Eyes with no ICC showed no intercalary membrane break, and none of the conforming variants showed ICC. In all the 5 eyes with ICC on OCT, there was a dark hyperreflective area surrounding the margin of the coloboma in the multicolor image, as I already stated, and the orange color boundary surrounding the dark hyperreflective area was seen in 4 out of the 5 eyes. This is a demographic analysis, which I just mentioned. So here are a few examples from the study. So here is one figure, which is left eye, which shows a pigmented variety of the macular coloboma, which is the conforming type. In the second image, we can see a vertical line passing through the macular coloboma. The margins of the macular coloboma are delineated with the white arrows, and it shows the intercalary membrane continuous with the excavation of the coloboma, which is suggesting the conforming type. And no break of the intercalary membrane is identified in this, and also there's no intrachoroidal cavitation. This is another example in the study where we can see the pigmented variety of the macular coloboma. The margins are marked with the white arrows. The OCT shows that the margins of the macular coloboma is white with the white arrows. The intercalary membrane is marked with the yellow arrows, while the sub-ICM space of detachment is denoted by the pink arrow. There's no break in the intercalary membrane in this also, and no ICC. This is a third example, which shows the pigmented variety of macular coloboma. Here we can see that it's extended beyond the margins of the coloboma, and the dark green patches are noted, which correspond with the areas of the intrachoroidal cavitation, which are shown by the red arrow. There's no orange color boundaries in this case. It shows the intercalary membrane break shows by the blue arrow, thereby so you can see in the ICM space of the detachment. And this has been described as a non-conforming type of macular coloboma. Here the ICC is noted as a hyperreflective space beneath the unaltered RPE. So macular coloboma can be of two types, the conforming and the non-conforming type. The conforming type is further divided into the one which has no intrachoroidal cavitation, and the non-conforming has the one with no intrachoroidal cavitation and with the cavitation. It is described like I already did. So in conclusion, we can say that ICC is seen in all eyes with non-conforming macular coloboma with the presence of intercalary membrane break and detachment on OCT imaging. These are identified on multicolor imaging as dark green areas abutting the margin of the coloboma. The limitation of the study was lack of information on long-term changes in eyes with or without ICC, and the take-home result is that eyes with macular coloboma tend to show intercalary membrane break and detachment and needs to be followed up at regular intervals for checking the development of ICC. Thank you.
I think the major role of multicolor imaging is the basic thing.
Yes, sir.
So what is the cost for this? Yeah. So, you don't know, doesn't matter. Thank you very much.
Thank
yeah,
you,
it's the new technology which is coming, it is being made applicable to all these things.
Just one question. In your series, you didn't have any retinal detachment. What could be the reason for that? There was a break in the intercalary membrane,
Yes,
but
sir.
no detachment.
So the retinal detachment might have occurred later in those patients. These are all a retrospective study. So we couldn't follow up. At that time, it wasn't there.
Yeah.
But maybe later on, it might have happened, but we couldn't these patients were done like retrospectively. So we already had the images and we tried to analyze them.
So you need a long-term follow-up for that.
Long-term follow-up is definitely required in such patients. That's what is the take-home message. Thank you.
function correlates with foveal
Slow.
slope, retinal choroidal thickness on OCT in type 2 McTel. Please.
Should I start?
Yeah.
Good morning everyone. My topic for presentation is visual function correlation with foveal slope, retinal choroidal thickness in OCT in type 2 McTel cases. No financial disclosures. Type 2 McTel is a neurodegenerative vascular disease primarily affecting the deep capillary plexus. It is associated with changes in inner and outer retinal structures, ultimately leading to abnormal neovascular complexes. It is an idiopathic bilateral occult foveal disease affecting the elderly between 5th and 7th decade of life. The visual symptoms in type 2 McTel are subtle at first and may include slow vision loss, blurred vision, distortion of vision, difficulty in reading, and a scotoma in the visual field, which affects the quality of life. Severe vision loss is rare and depends on the presence of foveal photoreceptor layer atrophy, with or without SRNVM, affected McTel on the fluorescent angiography, and reduced retinal thickness within McTel area. The variety of retinal imaging modalities such as FA, OCT, confocal blue reflectance, FAF, microperimetry, multifocal ERG, and recently multicolor imaging in OCTA have been used for diagnosis and identification of the stages. A number of factors such as subjective response and media opacities can affect the reliability of these imaging modalities. In addition, these imaging modalities are not commonly available at a small scale retina practice. The retinal OCT imaging technique is a non-invasive, commonly used tool for documenting a structural changes at macula in type 2 McTel, which is commonly available in a small scale practice. The aim of this study was to correlate altogether different OCT measurements such as foveal slope angle, peri and parafoveal retinal and choroidal thickness, stage-wise and quadrant-wise, with visual acuity in type 2 McTel. It was a retrospective observational study in which the clinical records with gradable quality of macular OCT images were seen and between January 17 and December 2020. It was a retrospective study, so a waiver for informed consent was obtained. The diagnosis of type 2 McTel was based on the constellation of clinical findings as described by gas and bloody, and other imaging features using confocal blue reflectance, FA, and OCT images. Eyes with OCT images having more than 3 months of follow-up are included in the study. Exclusion criteria was patients with associated macular pathologies or patients with media opacities which did not allow for good quality of OCTs. Based on different clinical and retinal imaging features, eyes were classified into stage 1 to 5 as suggested by gas and bloody. OCT scans were obtained following pupillary dilation using spectralis machine. Volumetric scan 30-degree scanning area was obtained. Scan quality with more than 20 score was used for analysis. Foveal slope angle measurement. It was measured in all 4 quadrants with, at 500 microns from the foveal center. The measurement was calculated using tangent function on the ratio between the difference between the temporal quadrant thickness and subfoveal thickness divided by the 1000 microns, which was the distance between two measurements. Retinal choroidal thickness measurement. For retinal choroidal thickness, a vertical and horizontal line enhanced EDI image was used. The measurement were done by 2 independent mass trained retinal specialists. The RT was measured in an automated fashion from internal limiting membrane to outer border of RPE. For measuring choroidal thickness, the outer choroid sclera junction was identified and cross-checked and then measured. All data was analyzed using GraphPad Prism 9.1. The Safarov-Wilk normality test was also used for normality data. The Snellen's vision chart was converted to logMAR vision for statistical analysis, and inter-rater reliability coefficient was also calculated. Results: in total, 92 eyes of 49 patients were included in the study. 49% were male and 51% were female. Mean age was 59.6 plus minus 8. As per clinical and retinal imaging findings, there were 39 images of stage 1, 44 of stage 3, 19 of stage 4, and maximum was stage 5. There was no stage 2 noted in any of the cases. The relationship of McTel disease stage with foveal slope and visual acuity. With advanced stages of disease and a decrease in visual acuity and foveal slope angle in all 4 quadrants were noted, which was significant with P of less than 0.01. Relationship of McTel disease with retinal thickness and visual acuity. With more advanced disease, there was reduction in retinal thickness in all the 4 quadrants and parafoveal quadrants. Choroidal thickness, there was no correlation was identified in the choroidal thickness with the disease severity. change in temporal foveal slope and angle at the final visit. No significant change was noted in the FSA with visual acuity at the difference between the baseline and the final visit. Discussion: the current study evaluated the role of foveal contour irregularity changes in retinal and choroidal thickness in peri and parafoveal regions in determining the visual acuity. The results of the current study suggest that the splaying of fovea and reduction in retinal thickness within mactal area have an association with visual acuity. Changes in choroid did not have any impact on the visual acuity. The decision to study these three parameters on OCT and its correlation with visual acuity was based on their involvement in stages of type 2 mactal. The objective measurement all obtained with a spectralis machine and measuring the values all were well described in the literature. And these three parameters are known to affect the visual acuity in other macular pathologies as well. One of the earliest signs of type 2 mactal on OCT is enlargement of foveal pit, which then appears asymmetric with thinner sector located temporally to the anatomic foveal center. This minor structural alteration seen in foveal contour occurs due to change in the outer retinal and Henle's fiber layer thickness. The retinal thinning in affected mactal area results in loss of structural integrity due to Muller cell involvement, thereby affecting the foveal contour irregularities. There are few other studies who have tested the correlation of retinal thickness with visual acuity in mactal. Charbel, Issa et al. And Jaishankar et al. Noted no correlation in central macular thickness and visual acuity in patients with type 2 mactal. Another report of mactal study group showed poor vision in patients who had reduced retinal thickness in mactal area. Limitation: the major drawback of this study was a retrospective study, and it did not correlate, the study did not correlate retinal and choroidal thickness longitudinally.
Please, you have overstepped the time. Finish it now.
The visual acuity correlates with better FSA and RT quadrant-wise and stage-wise. The conclusion is smaller the temporal FSA, poorer the vision. These are the references. Thank you.
Any questions? Smaller foveals, more
Slope angles. Is that automated parameter? I mean, we can calculate, or you have to spend time
No,
calculating?
we have to spend time calculating.
How much time does each case take?
For calculating around 5 minutes.
So it's a bad omen if the angle is smaller,
Smaller, yes, sir.
and especially on the temporal
Temporal
side.
side, yes.
Thank you very much. Please call the next speaker. आपको call करो. Third one. Yeah, Harshita Nahata. So she is speaking on differences in choroidal morphology between eyes with macular PCV and peripheral PCV using ICGA and OCT. Dr. Harshita Nahata. Start, please.
Good morning, everyone. So I'll be speaking about peripheral and macular PCV, which is a retrospective comparative case series. Now, what exactly is polypoidal choroidal vasculopathy or PCV? It is a disease of the choroidal vasculature which is characterized by presence of multiple serosanguinous or hemorrhagic detachments of the RP with extensive intraretinal or subretinal exudation, most commonly seen at the macula and peripapillary region. Now, what is peripheral PCV? Peripheral PCV is a subset of a wider disease entity or a PEHCR, which is characterized by peripheral subretinal hemorrhage, sub-RP hemorrhage, subretinal fluid and exudation, most commonly seen involving the temporal periphery between the equator and ora. Why is it important to study the differences between macular and peripheral PCV? Now, studies have shown that the normal choroid, which is normal subfoveal choroid, is thicker and tapers off to the periphery, giving a normal bowl-shaped configuration. Whereas in peripheral PCV, the choroid is thinner subfoveally, giving it a club-shaped configuration. Now, to the best of our knowledge, there have been no reports comparing the clinical, imaging and treatment outcomes between eyes having peripheral PCV and macular PCV. Hence, we did this study to compare clinical and imaging features and treatment outcomes between eyes having peripheral and macular PCV. Ours was a retrospective comparative case series with confirmed cases of peripheral and macular PCV on ICGA done between July 2017 and June 2021. To diagnose a case as macular or peripheral PCV, hyperfluorescent spots were to be seen on the ICGA, which leaked if they had abnormal vasculature on FFA. Now, we excluded patients with history of ocular trauma, inflammation, tumor, or have patients having a very high myopia, or patients in which conditions, who had a condition which reduced the angiographic image quality, for example, poor dilatation, VH, or advanced cataract, and hence could not allow the identification of polyps. We did the data recording as per the demographic data with patient characteristics, location of polyps on ICGA, leakage from vascular network on FFA, presence of dilated choroid and Pachy vessels on macular OCT, and modality of treatment and outcomes. Our results were somewhat interesting. We saw that the mean age in the peripheral PCV group was significantly higher than the macular PCV group. Coming to the clinical features, now the macular PCV group comprised mostly of phakic patients. Subretinal heme, median number of polyps seen on the ICGA was more in the peripheral PCV group, whereas hard exudates and abnormal vasculature seen on ICGA and leakage on FA was more in the macular PCV group. Coming to the OCT features, we saw that the involvement of macula by fluid, PED, heme or exudation was more in the macular PCV group. Also, the subfoveal thickness was significantly higher in the macular PCV group. Patients with peripheral PCV mostly were treated with observation, transscleral cryo or focal laser, whereas patients with macular PCV group were treated mostly with anti-VEGF therapy. Now, this is one of our cases from the peripheral PCV group, wherein an 80-year-old female who came to us had extensive subretinal heme temporally on ICGA seen as multiple hyperfluorescent spot in the temporal periphery. On OCT, we saw that there was a normal foveal counter, but there was subretinal heme in the temporal periphery with a thinner choroid at the fovea. Now, this patient remains stable till date, 2 years later, after 3 rounds of cryo and 1 round of focal laser. This was our second patient from the macular PCV group, who was a 60-year-old male who came with extensive subretinal hemorrhage at the posterior pole, extending nasal to the disc. We saw few hyperfluorescent spots superior to the disc, along with abnormal vasculature. On OCT, the foveal counter was maintained, but there was a lot of subretinal heme subfoveally and a thicker choroid. Now, this patient, after 3 years of treatment, also remains active with despite 8 doses of anti-VEGF, and the vision has deteriorated from 20/40 to 20/200. Thus, to summarize, peripheral PCV is commonly seen in an older age group. Hemorrhagic features are more common than exudative features in the peripheral group. Detection of abnormal vessels on ICG and identification of leakage from BVN or FA are not frequently seen in the peripheral group. The choroidal thickness at the fovea is thinner in eyes with peripheral PCV, and treatment mainly involves direct treatment to the polyps by transscleral cryo or direct laser. We had a few limitations because of the rarity of the disease, which was a smaller sample size. We also could not look at the peripheral choroidal thickness differences between both the groups. In conclusion, peripheral and macular PCV cases are two separate clinical entities having distinct pathogenesis, clinical and imaging features, and treatment outcomes. Hence, further studies are needed to understand the pathomechanism in these distinct disease entities. Thank you.
So your decision regarding cryo, how do you take it for the peripheral? You first try anti-VEGFs and then go for cryo, or you directly go for cryo?
No, sir. We directly go for cryo in the peripheral PCV.
Does it increase the exudation post-cryo immediately for some time? How do you expect how much time you expect the exudation to go off?
Sir, mostly the peripheral PCV group, we saw that they had more of hemorrhagic features than exudative. So after cryo also, we did see exudation, but most commonly what we could see was post-cryo there was exudation, and if at all there was a bleed again, then we went on and did a cryo for those patients.
And you said you did 3 times cryo, so how do you decide?
For that patient, sir.
Okay, so how do you decide that you do the next cryo?
So if we see that there is a constant leakage, we keep following up the patient very frequently.
So do you do repeat ICGs also?
Yes, sir. Not every time, but when once we see that for us the disease does not look active, then we do confirm it on cryo and on ICG and FFA both, to see if there are any existing polyps and also if there is leakage, which we can see on the FA.
Have you done any OCT angiography to detect BVN in such cases?
Yes, sir, we have done OCT, but sir, since this was a retrospective series, so for all patients we could not go and find out, hence we could not include the OCT findings in our study.
Yeah, thank you very much. Please call the next speaker.
Yeah, now I call upon our next speaker, Dr. Rahul Mangla. She'll be speaking on anatomic and functional outcomes of arch-shaped SRF in wet AMD.
Good morning, sir. Today I'll be presenting on anatomical and functional outcomes of arch-shaped SRF in wet AMD. So very often in clinics we see these type of chronic CNVMs and we are confused whether to leave them alone or to treat them. So in 2016, Fenniken et al. Came up with the article arch-shaped SRF in age-related macular degeneration. They defined bridge-shaped SRF as a fluid accumulation in the subretinal space which were mainly limited laterally due to the adhesion complexes between the CNVM and neurosensory retina. They went on to give 3 monthly ranibizumab injections followed by PRN dosing. They concluded that mainly there were type 2 fibrotic CNVMs and there was improvement in the SRF resolution after 3 monthly intravitreal ranibizumab, but resulting in poor visual outcomes. But the study lacked baseline predictive characteristics of CNVM, which could prevent the development of bridge-shaped SRF and help us in achieving good visual outcomes. So we did this study with the aim of completing out the factors of the bridge arch-shaped SRF on OCT in wet ARMD and to study the anatomical and functional outcomes. So we took on our OCT-based data, the neovascular AMD, out of which we took predominantly scarred CNVMs, and we took out the bridge arch-shaped SRF, and we studied the clinical and OCT profile of the before the development of arch-shaped SRF, at the time of development, and last follow-up visit. We also defined the bridge arch-shaped SRF as a bow-shaped SRF with neurosensory detachment. We documented best corrected visual acuity at presentation, at development of bridge arch-shaped SRF, and at the final visit. We also documented treatment received before development of SRF and after development of SRF. We also studied the OCT features such as level of the CNVM, whether it was a single or a multi-compartment SRF, the height of the SRF, presence of the RPE tear, and greatest linear dimension of the RPE tear. So we found that there were 821 eyes with the neovascular AMD, in which 623 eyes were predominantly scarred CNVMs, out of which the 24 eyes had bridge arch-shaped SRF. So we saw that the bridge arch-shaped SRF, the mean visual acuity was 30 letters, while the OCT features at the time of presence of bridge arch-shaped SRF mainly was type 2 CNVM, that is accounting to 75%, and type 1 CNVM was found to be 25%. We also saw that the presence of RPE tear was 33%. And in the 14 eyes where we had the OCT prior to the development of bridge arc-shaped SRF, we found that the mean visual acuity was more, that is 53 letters, and type 1 CNVM was more, that is 79%, while the type 2 CNVM was just 21%. We also found that the mean time interval for the development of bridge arc-shaped SRF was 22 months. So we found that the time of development of the bridge arc-shaped SRF was 22 months. Also that the vision had dropped from 53 letters to 30 letters, and there was a conversion of type 1 CNVM to type 2 CNVM. So in a case series, we found that at a gap of 15 months, the type 1 CNVM in picture A had changed to type 2 CNVM with the arc-shaped SRF with adhesion complexes. So in our study, the 77% of patients received intravitreal anti-VEGFs. Mean number of injections received were 4, and there was a complete resolution of SRF at the end of 1 month only in the 68 eyes, while the 82% of eyes had the complete resolution of SRF at 3 months. Also, there was only 4% of patients where there was improvement of more than 5 ETDRS letters, while the 60% of the eyes at the final visual acuity was worsened. There was also recurrence of the SRF in 18% of eyes. In this patient also, she was an 81-year-old. The patient had bridge-shaped SRF and type 2 CNVM with 1 brolucizumab injection. We did achieve the anatomical closure, but there was no visual acuity improvement. In 22 eyes, there were, where we had the last follow-up details, we found that the mean time interval from bridge arch-shaped SRF to final visit was 26 months, and at the final visit, mean visual acuity was 24 letters. So we found that the bridge shaped SRF could be from type 1, it changed from type 1 CNVM to type 2 CNVM because of maybe RP breach, RP tear, inadequate treatment, and these release the profibrotic factors leading to submacular scarring and fibrosis, and thus leading to bridge arch-shaped SRF. So we concluded that aggressive treatment is required to prevent the bridge arch-shaped SRF. Also, 68% had complete resolution at 1 month, 82% eyes had complete resolution at 3 months. There was 7 ETDRS letter reduction in visual acuity, and the patients were treated on PRN dosing. So aggressive treatment with monthly injections is needed to prevent the vision loss. The weakness of the study was that it was a retrospective study, it was a small cohort, and no comparative groups we had, no comparison of response to different anti-VEGFs was seen. The strengths were that it provided characteristics of the CNVM prior to bridge arch-shaped SRF and pathogenesis and final functional outcomes of bridge arch-shaped SRF. So to conclude, predominantly scarred type 2 CNVM with subretinal fibrosis and adhesion complexes between neurosensory retina and CNVM RPA complex, their presence suggested fibrotic enlargement leading to poor visual outcomes. Thank you.
Thank you. So appearance of this R-shaped SRF, that is a bad omen.
Yes, sir.
I mean, the results, because mainly fibrovascular tissue is there, and vision may not be achieved.
Yes.
These patients, I think, should be counseled very wisely, because they are the people who can cause a ruckus because vision is not improving.
Yes.
We are saying the treatment is the things are under control, and these are the people. And if a person is junior, he should, I think, he should refer it to senior one. Even I refer it to my colleagues, so that because visual outcome is not very good, and I may not be able to handle it. Thank you.
Thank you, sir.
The next paper will be presented by Ajay Dudani, my friend, and he'll be talking to psychiatric evaluation in patients with central serous choroidopathy in Asian Indians. I think he has been dealing with this topic for a long time.
Yeah, good morning. Thank you for your kind introduction. So we are talking about the study which we are doing about psychiatric evaluation of patients with CSCR. We all are aware what is CSCR. It's an idiopathic localized serous detachment. It's usually unilateral and may be associated with pigment epithelial detachment. So the aim of this study was to, see the incidence of, type A personality patients developing psychiatric disorders and the effectiveness of treating them with oral anxiolytic treatment. So we had a double-blind study of 60 patients. The materials and methods, we did FFA on the first visit and 1 month follow-up, and OCT as and when required on every follow-up. All patients underwent independent psychiatry and psychological workup by a psychiatrist. So this is the detailed evaluation which went, and the psychiatrist itself started the treatment with monotherapy of using etizolam or clonazepam, or a twin therapy of adding escitalopram, which is a SSRI inhibitor, along with lifestyle modification. And we followed up these patients from 6 months to 1 year. This is how the psychiatric evaluation paper was. They were diagnosed either as major depressive disorders or anxiety disorders. And the patients received the treatment from the psychiatrist's point of view. And we just followed up these patients to see the resolution of the CSCR and vision improvement. So as per the DSM-5 classifications, we all will come into one of the categories, and we all will be psychotics. That's how the intensive the classification is. So what is the basic results which we observed is that there was visual improvement in all cases, almost to 6.6, 6.9. In chronic CSR patients, the vision was not improved beyond 6.12 because of the RPE changes and the foveal thinning. So a few cases I'll share with you all. This is how one of the cases had this subretinal fibrin to resolve rapidly. You can see within a month and a half of treatment. This is another case which also resolved with treatment with anxiolytics and SSRI inhibitors. Again, you can see even the subretinal fibrin does tend to reduce, though here you can see there's a coagulum which has formed. Even in patients who had these ink blot leaks, once we treated them, this was the OCT with PED, how it resolved rapidly, and even the leaks were disappeared after treatment with these anxiety drugs which the patients were started on. So here you can see another case, of a 40-year-old man with chronic CSCR with and this is the resolution with etizolam, and it stays flat, develops a small SIRE. This is again a 30-year-old male. They are all, typically, and during this COVID, you must have seen that due to stress, there's a really increased incidence of CSCR. And rather than waiting for these patients for a long time, if you can start them with these anxiolytics, which I've started in my private practice after these studies, you have a very rapid resolution of CSR, as you're seeing, along with visual improvement. But these cases, it's not like a panacea treatment. It does tend to recur, and large and big CSRs maybe don't resolve very well with etizolam, and they require to be added with SSRIs, and then they definitely do better. And in the end, they all turn out to be flat, but you can see the foveal atrophy which develops in a chronic CSCR patient. So the observation which we had in about 60 patients was 10 had major depressive disorders, 24% had mixed anxiety disorders, 6 had adjustment disorders. So these are all classifications which was done by our psychiatric department. And 18 had anxiety due to general medical condition. 3 patients definitely required low fluence PDT, so not necessarily it's a panacea treatment for all these patients. So this study demonstrates the effectiveness of treating these patients. So now we have moved ahead and we are independently treating these patients. Now we did an extension of this study was that whether there was the severity of CSR and the severity of the psychiatric disorder, like the patients who are having, maybe you can say depression, are developing more of elevation of CSR and more chronic. So we did this DAS study, it's a depression anxiety stress scale, which is a sort of a questionnaire which the patient replies on. So we compare the degree of CSCR and the degree of stress, as per this chart. So in this we had a subset of 33 patients which this is a follow-up of further patients, and we had a duration of 2-year study. So case diagnosed, OCT, FFA, psychiatric reference. So most patients, what we saw in this result was of the upper lower class. This is the classification of DSM book of the classification of the socio-economic state. Acute cases in younger age, whereas chronic cases in more elder age group. There was psychiatric morbidity in almost 60% of the patients, and the higher the score of DAS, that is the questionnaire which we gave them, larger was the area of detachment. As you can see, this graph shows the degree of CSCR and the degree of psychiatric disorders, mild, moderate, severe, And this is the area under the graph, so the patients who have more severe psychiatric disorders have a larger area of subretinal fluid. So conclusion which I drew from this small study is that stress is relatively more common among patients. The degree of severity of CSCR in the area of neurosensory detachment is significantly associated with the severity of depression and anxiety, but we require further study with a larger sample study and a prospective trial to have a better outline of this, because our sample size was relatively small. This is a publication which I had on the same study which we had done, which was published in IGO. And we also had this anxiolytics as a treatment, which shows one of these cases which resolved permanently over the last 2 years with a single dose of 3-month therapy of anxiolytics in this patient. So just to end with this last slide of my friend who's done a lot of work on CSCR, that means that this young population is definitely upset, and 20 by 60 definitely affects the visual quality. So CSCR is not as benign as a condition as we feel. Scleral thickness and norepinephrine increases the sympathetic nervous outflow, which leads to a pachychoroid, and that leads to CSR exudation. This was also described by Januzzi, where he said it's a biochemically adrenergic mediated phenomena, so which increases the permeability of choriocapillaries. So this is our this is our etiopathogenesis. So this basically anxiety leads to catastrophization and disrupts the serotonin levels in these patients. So this is how, stress leading to corticosteroids and CSR and SSRIs preventing it. Thank you very much for your patient hearing.
Thank you, Dr. Ajay. Nice presentation, but I would like to ask you one thing, that all these patients were newly diagnosed with psychiatric disorder, or they were already known psychiatric patients?
Yeah, very good point. So these were all patients who were newly diagnosed by us. So we were doing in our medical college, all CSCR patients were sent to the psychiatry department, and then they started the treatment. So these were de novo psychiatric patients who were having CSR. So they primarily came to us and we referred them to the psychiatry department.
But I think if we have any ocular disease or any disease which affects vision, maybe all the patients have this anxiolytic disorder.
Very true. I think
so
especially
we should have a control group with other patients also, because anybody having disease would have
so we had a control group of CSCR, also in these patients who didn't have this any psychiatric disorder also. But I've seen what you're saying is true. We had a control group in the second study which we did, that the degree of psychiatric disorder and the degree of CSCR, it was correlating even to that. So, we tried to go further ahead in that thing. So after this study, I usually, in your private practice, you obviously can't send your patients to psychiatric patients, but retrospectively after this study, I've started doing that routinely for my patients, and the rapidity of resolution of fluid is, remarkable in these patients, because when you take history, you get some idea when the patient tells, like, he's undergoing either financial or a family stress, which is common, and COVID has come up with more of this, is what I feel.
So in fellowship program, we should have some psychiatric training also.
Yeah. Thank you so much.
Thank you. Thank you, Ajay. Inviting next presenter, Dr. Deepashri.
Good morning, everybody. My free paper presentation is on OCT features in type 2 MACTL, its relevance with clinical staging and visual acuity. So the term type 2 MACTL has been classically described as a disease of an elderly, which is seen usually bilaterally, and it is non-familial and idiopathic. It affects the macular Muller cells and the capillary network, and it is associated with changes in the inner and outer retinal structure and abnormal neovascular complexes. There are two broad classifications which are described by Gass and Blody based on only clinical picture, and Januzzi based whether it is in a pre-proliferative or proliferative stage. The MACTL study project, which was initiated in 2005, is a collaborative study to determine to get a better understanding of clinical features of MACTL, and to study the natural history of disease and its pathogenetic mechanisms. The objectives of our study was to describe the SDOCT imaging features of type 2 MACTL and to see the relationship with the different clinical stages on fundus examination and visual acuity, and to establish a connection between SDOCT findings and disease pathogenesis. It was a retrospective observational study which was taken on a large cohort between January 2011 and December 2020. All the clinical records and SDOCT images of these patients were retrospectively studied, and there was a waiver of informed consent obtained. So based on the clinical imaging and blue reflectance imaging and SDOCT and fundus fluorescein angiography, the following study was done. All the patients with concomitant macular pathologies and dense media opacities were excluded from the study. So as in this picture you can make out, there are different features based on the SDOCT findings from the inner retina towards the outer retina. Initially we can see that there can be a loss of normal foveal contour and hyperreflective middle retinal layers, which is a classic finding of type 2 MACTL, and a small intraretinal cavitation, that is hyperreflective cavities can be seen along with hyperreflective middle retinal layers. Sometimes there can be intraretinal crystals which do not have classical backshadowing, and it can be associated with subretinal fluid pocket. Here we can make out there is outward turning of the inner retinal layers. Sometimes this retinal pigment epithelium clumps can get migrated to the superficial retina with classical backshadowing, and here you can make out that there is hyporeflectivity in the outer retinal layer suggestive of subretinal fluid, and here the classical ILM drape sign can be seen along with subretinal neovascular membrane, and in this there is hyperreflectivity in the inner retinal layers with subretinal neovascular membrane suggestive of retinochoroidal anastomosis. So these are all different varieties of presentation of type 2 MACTL on SDOCT. So here in our test we applied the following statistical test. The Shapiro-Wilk normality test was used to test the normality of the data tests, and Snellen's vision data was converted into logMAR. Different OCT imaging we had given the numbers and percentages, and the quantitative variables between the two groups we analyzed by Mann-Whitney U test for non-parametric data and unpaired T test for the parametric data.
and chi-square test was used to compare the categorical data between the two groups. The correlation between different SDOCT markers and visual acuity were analyzed using Spearman's correlation test. So multiple variable linear regression analysis was performed between the visual acuity as dependent variable and statistically significant SDOCT features on correlation matrix as independent variables. So p-values less than 0.05 were considered statistically significant. The results that were obtained out of this study was 212 eyes of 108 patients with findings of type 2 MACTEL were included for analysis. The mean age at first visit was 62 years and females were predominant in the study. All the patients were of Indian ethnicity and 75 of our patients had diabetes mellitus also. And the mean logMAR was 0.4. So in table 1, the various SDOCT imaging features and visual acuity changes in patients with type 2 MACTEL were seen, and it was seen that most common were irregularity of foveal contour, hyperreflective middle retinal layers, and hyperreflective retinal pigment clumps. So the OCT features noted in different clinical stages of type 2 MACTEL based on gas and body classification. We saw which clinical findings seen on which findings were seen on SDOCT and how it correlated with the gas and body classification. Similarly, it was also compared with the Januzzi's classification. So in non-proliferative clinical staging, we saw that the most common SDOCT feature was hyperreflective middle retinal layers, followed by hyperreflective inner and outer retinal cavities and ILM drape sign, and outward bending of inner retinal layers. In proliferative stage, the foveal contour irregularity was common, followed by hyperreflective retinal pigment clumps and presence of subretinal neovascular membrane or RCA. So in addition, what was seen was 25 of these eyes showed disparity between the clinical staging and disease on retinal examination and SDOCT features. So these were classically missed by gas and body classification or Januzzi classification. So the other analysis, when we went through the entire analysis, we got to know that most of the patients had hyperreflective middle retinal layers, and the proliferative stages had foveal contour irregularity and hyperreflective RPC and presence of subfoveal subretinal fluid. And foveal contour irregularity correlated with the poor visual outcome with outward turning of inner retinal layers and hyperreflective RPC, and poor visual prognostic factors in proliferative stage were foveal contour irregularity and hyperreflective retinal pigment clumps.
You finish off, your time is jumped off.
Thank you. So just the concluding slide.
Yeah, we'll like to call next speaker, Dr. Ramesh.
Am I ready to start? Yeah. So, good morning everyone. My topic for today's free paper presentation is choroidal retinal thickness variations in ocular albinism. My name is Dr. Ramesh Venkatesh and I have no financial disclosures to make. Not working. Slide, excuse me, the slides are not moving. Slide moving or no? So, can we restart? So my topic for today's free paper presentation is choroidal and retinal thickness variations in ocular albinism. We know ocular albinism is a genetic disease which is characterized by absent synthesis of melanin. It is an autosomal recessive or an X-linked recessive disorder which is characterized by poor vision, foveal hypoplasia, nystagmus, high refractive errors and misdirection of the optic nerve fibers. In albinism, there is failure of the emetropization which happens, which leads to high refractive errors, and the most common refractive error which has been reported is hyperopia. The choroid is a vascular layer which is located between the RPE and the scleroid, and therefore the choroidal thickness, it can push the retina either forward and the sclera either forwards or backwards, leading to leading to emetropization. And the choroid also produces some growth factors which affects the scleral extracellular matrix and can affect the emetropization. There is melanin which is present in the choroid and the choroidal melanocytes, and they can also be responsible for the choroidal thickness. And this is one of the papers which we had published recently talking about the impact of melanin on the choroidal thickness. And the absence of melanin in the choroid therefore definitely affects the choroidal thickness. And hence we decided that we should study the choroidal thickness variations and the retinal thickness variations on the enhanced depth OCT scans in ocular albinism and compare them with age-matched healthy subjects. Coming to the methodology, this was a retrospective case control study where the cases were eyes with ocular albinism and controls were age and sex match and axial length match subjects of normal people. So the diagnosis of ocular albinism was made on the basis of presence of nystagmus and photophobia, iris and fundus, hypopigmentation with or without systemic features, foveal hypoplasia and reduced visual acuity. Now the selection of controls were patients or were people who had a normal fundus with age and gender and axial length match, and the ratio of cases and controls was 1:1. The ocular examination of the cases and the controls included visual acuity documentation, refraction, slit lamp and IOP measurements, axial length measurements, fundus imaging and OCT imaging. The OCT imaging was done with the Heidelberg Spectralis machine for both the cases and the controls, where we looked at the retinal thickness measurements at the fovea and 500 microns on either side of the fovea nasally and temporally up to a 2000 micron length. The choroidal thickness was also measured in an automated manner at a distance of 500 microns on either side of the fovea at 500 micron intervals up to a length of 2000 microns on the OCT scan. Coming to the results, we had 48 eyes of 24 patients in both the cases and the controls, where you could see that the visual acuity was significantly affected in the patients in the cases. When coming to the retinal thickness and the choroidal thickness measurements, you could see that the retinal thickness in the cases was significantly higher than that in than the controls, and the choroidal thickness was significantly lower in the case group than in the control group. Even you can see that when you compare the measurements at each and every quadrant which we measured, there was a significant reduction in the retinal thickness measurements. Coming to the choroidal thickness measurements, also as we said that the choroidal thickness in the cases was significantly lower than that in the control group. So when you summarize our results, we can see that albinotics, they have a thinner choroid and they have a thicker choroid at the fovea, and the reason probably is the lack of melanin which is present in the choroidal layers and in the RPE. There is affection of the RPE melanin as well, and here there is an absence of melanin synthesis, but the melanocytes are present, and this is what needs to be differentiated from choroidal melanocytosis, where there is migration of the melanocytes from one area to the other. The thicker retina at the fovea can be explained by the presence of foveal hypoplasia and the persistence of the inner retinal layers at the fovea, which is responsible for it. Now, we compared our study with the findings which had been published in 2014 by Carabas et al., where they looked at 20 eyes of 10 patients in the pediatric age group, and they averaged the measurements in each quadrant, and they had poor quality scans were also included due to focusing and nystagmus. In our study, we had a larger number of patients. We included all age group of patients. We individually measured in each quadrant, and we had poor quality scans which were there. We excluded them from the analysis part. The limitations of the study was the absence of genetic testing. Most of the inclusion was based on the clinical examination itself. The presence of the nystagmus in the patients excluded most of the patients into the analysis. We neither did foveal hypoplasia grading nor measured the retinal thickness in each individual layer on the OCT scan, and the other choroidal markers like the choroidal vascularity index could not be assessed due to the average quality of the OCT scans. So to conclude, getting a high quality OCT scan in albinism is very difficult. The retina at the fovea was thicker and the choroid was thinner in albinotic cases. Based on this, we can understand that the choroid plays a primary role in the emetropization in these albinotic patients, and further studies are needed to evaluate the role of choroidal metabolism and its relationship to emetropization in ocular albinism. Thank you so much.
Thank you, Ramesh. Have you noted the thickness according to age? With the advancement of age, is there any changes in the?
Yeah, because we know that age, gender, axial length, refractive error all play an important role in the choroidal thickness measurement. So basically, when we included these subjects and the control group, it was all age and sex matched. So we definitely there was means age, sex, and axial length and refractive error were already neutralized before comparing between the two groups.
And how to get the good quality of OCT in the pediatric age group, because of lot of nystagmus is over there?
Yes, I totally agree. So what we do is that we look at the infrared image which is available along with the OCT scan. So in these cases with nystagmus, it's very difficult to get a good raster scan or a radial scans. So what we do is we take multiple line scans, single line scans, and based on the infrared image where we think that the fovea could be present, we pick up that OCT image which is of the high quality, and then we took it for the analysis.
Thank you, dear.
Did we correlate it with the visual acuity?
Yes,
because choroidal thickness with visual acuity.
Yeah, so if you look at the visual acuity comparison between the cases and the control group.
No, not cases control. Within the cases, did we correlate with the vision?
No, we did not look at the choroidal thickness, the correlation of the choroidal thickness and the logmar visual
then
acuity.
How does it help us? Like we are just saying pathogenesis of decreased thickness, that's it. But does it help us in our clinical scenario finding the choroidal thickness is less?
It explains that how the choroid and the melanin within the choroid, it plays an important role in the clinical diagnosis itself. Means you can know that in patients with albinism, choroidal melanocytosis, there is a lot of changes which happen in the choroidal thickness. That's what we know. But how much does it correlate with the visual acuity?
I think should be done.
Have you done any inter-observer reliability test?
Yes, sir. We have done inter-observer reliability in these patients. Thank you, sir.
Thank you, Ramesh. Can we have Dr. Girish Baliga, please? The topic is retinal detachment in eyes treated with AID for refractory glaucoma, incidence and outcomes.
My topic is retinal detachment as complication in eyes treated with Orolab aqueous drainage implant for refractory glaucoma, incidence and outcomes. So glaucoma drainage devices are fast emerging as the primary modality of treatment for refractory glaucomas. Rheumatogenious retinal detachment has been noted in 5% of eyes following Molteno valve implantation and 1.82% of eyes following Ahmed valve implantation. Retinal tear and dialysis are the most common causes of RRD following glaucoma drainage device implantation, and 41% of patients go on to develop proliferative vitreoretinopathy. So the aim of the study was to analyze the incidence, anatomic, visual acuity and intraocular pressure outcomes among patients with the pre-existing RD device who developed RRD and who underwent RRD repair. Now the RD device is a non-valved device which is modeled on the Barwell glaucoma implant. So it was a retrospective study between January 2013 to June 2020, and the data collected included demographic information, baseline and post-operative best corrected visual acuity and intraocular pressure, interval between RD implantation and rheumatogenious retinal detachment, details of RRD extent, break localization and surgical technique. Surgical technique was 23 gauge vitrectomy in all the cases. Cases which had choroidal detachment was drained as the initial step, followed by triamcinolone assisted core vitrectomy, PVD induction in all cases, membrane peeling wherever required. After fluid air exchange, drainage retinotomy was done in those cases where break was not identified. After fluid air exchange, 360 endolaser was done in all cases, followed by intraocular silicone oil tamponade. So when the RD tube was in the posterior chamber, it was repositioned in the anterior chamber to prevent oil drainage and hypotony. Sclerotomy placement and port closure was done meticulously to not damage the RD plate site, and scleral buckle or encircling band was not used in any case. So out of a total of 1,223 RD implantations which were done in the study period, 18 eyes developed RRD, out of which 12 eyes of 11 patients were included in this study. The mean age of patients was 28.2 years. There were 3 male and 8 female patients. Aphakic glaucoma was the most common type of glaucoma, and 5 patients had undergone prior ECCE and 3 patients had undergone prior trabeculectomy. 8 patients had anterior chamber tube and 4 patients had a posterior chamber implantation, tube implantation. The mean duration between insertion of RD and RRD presentation was 7.4 months. However, 60% of patients presented within 3 months of RD implantation. Type of retinal detachment, 8 eyes had total RRD, 4 eyes had inferior RRD. 10 eyes had 360 choroidal detachment, 2 eyes had suprachoroidal hemorrhage. However, preoperatively break could be identified in only 1 eye. Post-operatively, we had attached retina in 7 out of 12 cases. The most common complications were recurrent RRD, phthisis bulbi, glaucomatous optic atrophy. Post-operative BCVA improved from 2.49 to 2.34 logMAR units, and 58.3% of eyes had anatomic and functional success. That is, they had attached retina with either maintained or improved BCVA. 71.4% of eyes had successful IOP in eyes with attached retina, that is IOP between 5 and 21 millimeter of mercury with or without AGMs. So coming to the discussion, the instance of RRD in this study was 0.98%. So RRD following GDD can occur in eyes with predisposing factors such as trauma, uveitis, eyes with peripheral degenerations like lattice, previous intraocular procedures leading to vitreous syneresis, PVD, aphakic and pseudophakic status are also known risk factors. So what are the problems in RD management in eyes with GDD? That is, scleral buccal placement is difficult, and it is because of the presence of the GDD device, and it can also hamper the functioning of the RD plate. And post-operative hypotonia after RD implantation can cause choroidal detachment, suprachoroidal hemorrhage. It predisposes to RRD, makes preoperative assessment difficult, and surgery is also complicated. Tamponade with silicone oil can lead to worsening of IOP if there is oil in the anterior chamber. This compromises the trabecular meshwork. So why are non-wall devices more prone to retinal detachment? That is maybe because of the vitreous incarceration in these non-wall tubes, which can result in vitreous traction and retinal breaks. It's common with pars plana tubes, but this can also occur with the tubes placed in the anterior chamber if there is a concomitant posterior capsular rent. So how do we prevent retinal detachment during GDD implantation? We need to screen the periphery for any treatable lesions. A triamcinolone-assisted vitrectomy should be done during pars plana tube insertion, meticulous vitreous base dissection in that quadrant where the tube is placed, complete vitreous removal. The length of the tube in the posterior chamber should be 4.5 to 6 millimeter. This is to prevent basal incarceration of the vitreous gel. And even in eyes where the tube is placed in the anterior chamber where there is a disrupted posterior capsule, we need a meticulous triamcinolone-assisted anterior vitrectomy. So in our series, all cases were treated with PPV with silicone oil as endotamponade in view of the complicated nature of the cases. The most common complication following RD surgery is choroidal detachment. This is seen between 3 months and 1 year. So this leads to mechanical stress on the posterior ciliary arteries, leading to choroidal effusion, and large serous or hemorrhagic choroidal detachments can lead to adhesion of retina, apposition, and this could predispose to RRD. So we had 58.3% success rate of both anatomic and functional success. This is comparable to the previously reported series. However, ambulatory vision was only present in 2 of 12 eyes. IOP control was achieved in 71.4% of eyes. This is helped by ligating the tube with a 7-0 polygalactine suture at the time of detachment repair. And if the tube is present in the posterior chamber, it is brought into the anterior chamber through a peripheral iridotomy. However, subconjunctival migration of oil can still occur, which is troublesome. So PPV with silicone oil tamponade is a preferred approach in the management of these cases. IOP is usually well controlled in eyes with attached retina. Post-RD hypotonia and vitreous incarceration due to non-wall nature of tube are possible contributing factors. Functional and anatomical outcomes are poor due to pre-existing glaucomatous damage and recurrent retinal detachment. Combined effort between glaucoma and retinal services is needed to maintain functioning of the RD plate, prevent retinal detachment, and successful management of retinal detachment. Thank you.
So did you look at the retinal breaks? I mean, what was the localization of retinal breaks after this?
Madam, in preoperatively we could identify only
Just
in one
one,
case,
yeah.
because there was choroidal detachment was present in most of the cases, so the break could not be identified. Even intraoperatively, we could not find break in majority of the cases, so a drainage retinotomy was needed, maybe because most of the eyes were aphakic, so there could be micro breaks in the periphery which could not have been identified intraoperatively.
You used to drain the choroid first before starting the vitrectomy, or you would?
Yes, sir. Wherever there was significant choroidal detachment, which we use a 6 mm cannula and drain the choroidal detachment before starting vitrectomy.
And you do FG to help that before, because vitrectomy will be after you drain the choroid. So you would
Yes, sir.
put some gas or
Yes,
thing?
sir. Either we inject saline or we put in the 6 mm infusion, or wherever the infusion is not visible, we inject saline, and through the port site we drain the choroidal detachment and then commence the vitrectomy.
Thank you.
Thank you, sir.
Next.
morning, everyone. Today's my topic is real-world outcomes of sutureless and glueless scleral fixated intraocular lens implantation. There's no financial interest. Visual rehabilitation in aphakia remains unique surgical challenge where implanting of secondary IOL is required. Situations where placement of IOL in the bag or ciliary sulcus is not possible. The AC IOL, iris fixated IOL, sutured scleral fixated and sutureless scleral fixated IOLs are placed. SFILs are placed at a point closest to the nodal point. Sutureless technique of the SFIL avoids suture-related complications. Aim of our study is to report the outcomes of sutureless intrascleral fixation of 3-piece intraocular lens in the ciliary sulcus in a large cohort of patients with aphakia of various etiology. The methodology includes, it's an interventional retrospective study. Institutional ethics committee approval was taken. Basic demographic data, pre and post-operative data, and early and late complications were noted. The SFIL surgery was performed as a primary surgery or a standalone secondary surgery or in combination with anterior vitrectomy, pars plana vitrectomy or silicone oil removal. And the surgeons were also categorized as junior surgeons with less than 2 years in practice and more than 2 years in practice as seniors, and the complication rate was also compared. The surgical procedure includes the making a peritomy at 9 o'clock and 3 o'clock limbus with a two partial thickness tunnels with 1.5 keratome, around 4 mm in length. And a sclerotomy is made at 1 to 1.5 mm from the limbus with a 24 gauge needle. A bent 26 gauge needle is introduced through the sclerotomy, and the haptic of the IOL is introduced into the lumen and exteriorized, both at the 3 o'clock and 9 o'clock limbus, and the exteriorized haptics were tucked into the scleral tunnels. And the conjunctiva is closed. For the statistical analysis, BCVA is converted to logMAR and paired t-test, chi-square test were used. All patients with a minimum follow of 3 months were included and less than 3 months were excluded from our study. Around 250 eyes of 246 patients were studied with a mean age of 56 years and the mean follow-up was about 6 months. The various indications for which SFIL was done was surgical aphakia, traumatic aphakia, IOL-related causes and the ectopia lentis. And as I mentioned, it was done as a combination with anterior vitrectomy or standalone surgery or along with the pars plana vitrectomy or silicone oil removal. The mean best corrected visual acuity of 20 by 110 pre-operatively improved significantly to 20 by 60 post-operatively. In the subgroup analysis also showed the significant post-operative mean BCVA improvement. The most common early complications were the vitreous hemorrhage and late complications were the cystoid macular edema. Other complications noted were hypotony, high IOP, retinal detachment, IOL tilt, scleral erosion, IOL subluxation or dislocation. When the junior surgeons and senior surgeons were compared, in each group there was a significant post-operative best corrected visual acuity, and in between the groups there was no significant difference in relation to the visual acuity and also the complication rate. So technique of SFIL has been reported by many investigators for the management of aphakia. The above procedure avoids suture-related complications like suture knot erosion, IOL dislocation and IOL tilt due to the inaccurate suture placement. So our study showed a significant post-operative visual acuity improvement which was comparable to many other studies. There was 67% of eyes showed post-operative visual acuity improvement, 10% of the eyes showed same visual acuity, and 21% of the eyes shows deteriorated vision. This could be due to the corneal scar post-penetrating trauma, pre-existing retinal diseases, post-operative complications like cystoid macular edema and retinal detachment. Other studies also showed similar kind of deterioration, but they have attributed the cause to the trauma for which SFIL was done. Vitreous hemorrhage could be due to sclerotomies through the vascular pars plica and the bleed through the superior sclerocorneal tunnel. Post-operative IOP rise was due to inflammation and steroid response. Hypotony must be due to the leakage through sclerotomy site. So other studies also showed similar findings where the hypotony and VH were high because of the 20 gauge needles used for sclerotomy, and there was persistent hypotony and persistent IOP rise, which was not present in our study. Late complications were cystoid macular edema and retinal detachment, which could be due to the complexity of the eyes, and incidence of CME is usually high in the sutured SFILs. IOL tilt, IOL subluxation which were noted, it can be avoided by the incarceration of a longer part of the IOL haptic into the scleral tunnels. Advantages for our study are large cohort of patients with adequate follow-up, significant improvement in the mean BCVA, comparable post-operative complications, no significant serious complications. As there was no significant difference between the complication rate performed by various surgeons, it may indicate that current technique is relatively easy and safe with a lower learning curve. Limitations of our study are retrospective study, lack of long-term follow-up, no control group, and presence of confounding factors. To conclude, this modified IOL technique of sutureless, glueless, scleral fixated IOL implantation is cost-effective, safe and easier technique of aphakia rehabilitation in the absence of posterior capsule, provided a good visual acuity outcomes in a large cohort of patients, and it's well tolerated. Thank you.
What were the total patients with complications out of, I mean, percentage-wise? I think complication, you are very honest in showing that there are so many complications, and visual results are also good. I mean, 67% of
Mainly it was the vitreous hemorrhage, sir, which was more common, and it was very transient. Around 2 weeks it has
I
come
think
down.
20% cases.
Yes, yes.
So what was the cause?
That
Vitreous-
was because of the sclerotomies which we make through the pars plicator region with a sharp needle. That could be the reason for the blade.
The hemorrhage resolved of its own?
Resolved on its own, sir. None of them we have intervened, none of them were intervened for vitrectomy or anything was done for the vitreous hemorrhage.
Yeah. Have you compared these with the results of iris claw lens
No,
put posteriorly?
That was the limitation of our study because of there is no comparison or any.
Okay. I think that is a in thing these days. Many people are doing it, and I mean, all this time taken is so less. Cost is like for your center, okay. And I think all these complications of vitreous hemorrhage, etc. The only thing is you should be knowing how to clip it.
And what is the reason of using 24 gauge for sclerotomy? You can directly enter with 26 gauge anyway.
Yes, sir, but nothing particular reason, but if the size of the sclerotomy is little bigger, it is easy to manipulate the needle with 26 gauge needle.
Maybe the haptic of this PMMA lens is bigger, thicker. Maybe with foldable IOL, that PMMA part is thinner. Maybe 26 gauge will do.
No, but
but 26 gauge human it is entering.
Yeah.
Okay.
Did you suture the scleroscopy in the end? Like they said it was bigger than what is required. So did you suture it in the end?
No, ma'am.
Okay, I think we can have the next speaker.
So we now request Dr. Tapas Ranjan Padi, please. He is going to deliver keynote address, and I have to introduce him. He is a faculty at Vitreo Retina and Pediatric Retinal Services at L.V. Prasad Eye Institute, Bhubaneswar, Odisha. He is M. of Ophthalmology from JIPMER and a fellow Shankar Netralaya, Chennai, and he was a research fellow at University of Michigan, USA. His area of focus is ROP and complex retinal detachments. He has around 72 publications. He is in charge of ROP management in Odisha under National Health Mission. So he has already won AIOS S. Natarajan Award, and I request you to please take the dais, deliver your address. No questions on this address. Nobody can ask any questions. Yeah, this is a rule.
Very good morning, and thanks for the honor. With pleasure, I will take you through this interesting talk. The gain rate of retinal vascular outgrowth be a predictor for treatment in babies with retinopathy of prematurity. The disease is a disorder of immature retinal vasculature, and various factors including gestational age, birth weight, oxygen supplementation, weight at birth and weight gain, collateral health issues, genetic and factors unknown, they affect the incidence and severity of ROP through a common pathway, either deceleration of the vascular outgrowth or stoppage of vascular outgrowth at some point of time, which in turn leads to cascade of events leading to ROP and its severity. This common endpoint we exploited and tried to analyze what is the rate of retinal vascular outgrowth per week in treatment naive eyes with various groups of ROP, and can it be a predictor for treatment need. So this was a 10-year study, and partly retrospective from 2010 to 2019 and prospective from there onwards up to December 2019, and was approved by the Institute Ethics Committee. We included babies cared for ROP where the optic disc and the end of the blood vessels were visible clearly in one imaging field, and those with incomplete details, poor image quality, and no consent we excluded. We had two imaging devices. One is a RedCam shuttle, and where we use the inbuilt editing, the caliper to do the calculations. So all the calculations were made in terms of disc diameter to avoid the image magnification issue. Say for example, the distance of the end of the blood vessels were measured in terms of the horizontal disc diameter. We calculated all the quadrants including supranasal, supratemporal, inferonasal, horizontal nasal, and horizontal temporal, whatever available to us. And also we did calculations individually in each quadrant. Two retina specialists masked to post-menstrual age and treatment need did all the calculations, and a third examiner cross-checked. This is the the image with the Trinetra Neo, where the red-green image enhancement was used to make the blood vessels stand out. The formula used was this A divided by D. A is the distance of the end of the blood vessels. D is the horizontal disc diameter divided by P minus 17. So this is the PMA at presentation, and we assume that the blood vessels reach the end of the margin of the optic disc at 17 weeks of gestational age as per published literature. So say for example, the blood vessels here, now this is in disc diameter A divided by D, and this interval of time from 17 to the PMA that we are examining is the interval here P minus 17, and the rate is here. So midpoint of temporal or nasal disc margin till the vascular ending were calculated. These are the statistics used in both descriptive statistics and ROC curve and interclass correlation to find out reproducibility between the observers. So there were 436 eyes from 233 babies grouped into group 3, no ROP. So they are prematurely born baby but no ROP, they acted as control. Group 2, 108 eyes, spontaneous regression, ROP that regressed on its own without treatment. Group 1, 238 eyes, the treatment warranting ROP subgrouped into threshold, hybrid, APROP and high risk threshold. And the rate of vascular outgrowths are this. The lowest was in the treatment warranting ROP, that is 0.49 plus or minus 0.12 disc diameter per week, followed by group 2 and followed by group 3 with no ROP, where the vascular outgrowth rate normally was 0.7 disc diameter per week. The subgroup analysis in the treatment warranting group showed that the vascular outgrowth was lowest in AROP, as we see here 0.38 disc diameter, followed by in other groups. This is the, again, subgroup analysis within the aggressive retinopathy of prematurity, which is the lowest outgrowth rate, showed that these are the different rate in the different quadrants, and the speed in the nasal quadrant was much less than the temporal quadrant. In majority of cases, supratemporal and inferotemporal quadrant had calculations were there. Speed versus treatment need, whenever the values speed was less than 0.4 disc diameter per week, we saw that almost 100% required treatment. Now when we plotted the receiver operative characteristic curve, we found that the best cutoff was 0.56, and at different cutoffs, these were accuracy of predictability of the rate. So finally, the limitations included all the measurements were done on a flat screen. Actually, in reality, the blood vessels travel in a curved eyeball. So these our measurements are an approximation. Now locating the end of the blood vessels was difficult with the existing camera. We used the red-green enhancement technique to make the blood vessels stand out. The rate of vascular outgrowth was assumed uniform through the period of time, but in reality they change. So the next phase of study would be to see that how the rate changes over time. The rate is different in different quadrant. We try to obviate this by using the average. Issue of reproducibility. we used two examiners, and error due to the magnification, we used a ratio rather than absolute value. So the strength include retinal vascular growth can be quantifiable with many extrapolations, mostly post anti-VEGF injections. They can be of the rate can alert one that these are the babies who would need probably treatment, and observe them closely, and they can be a good tool for artificial intelligence in case we come up with good artificial intelligence in ROP management in future. The rate is inversely proportional to the this disease severity, lowest in AROP and slowest in horizontal nasal quadrant. At a rate less than 0.54 disc diameter, this is a good cutoff and a high probability of treatment need. So just for example, you can see a case of ROP, normal, no ROP. You can see that this is the graph showing the normal retinal vascular outgrowth, but a AROP, aggressive retinopathy of prematurity, almost the growth is flat. This is again another case. You can see that post anti-VEGF injection, the blood vessels are not going beyond this. This radiation alert, the speed was around 1.13 disc diameter per week. We had a very high alert that this baby will require treatment. You can see that subsequent follow-up developed new blood vessels, angiogram showing leak, and a laser was done. So thank you so much.
Very impressive address, sir. Thank you very much. And we request the next speaker, please, if he is there. Chhattisgarh Society, he's Dr. Chaya Bharti. She is there? Oh, sure, come on. Another Dr. Arnav Singh Saroya is there? Oh, yeah, thank you.
A very good morning to all. I'm going to talk on a small instrument used in secondary IL called as MyXnet. We can also call it homemade XNet. It's a modified form of XNet by Orolab. So how to make it? The XNet by Orolab uses 26 gauge needle and a silicon stopper, while I have used a 30 gauge needle on a 2 ml syringe, and the stopper is a piece of 240 band. In case of XNet by Orolab, it's a silicon material made stopper. So the surgical procedure, we make two markings, one parallel and perpendicular to the limbus, 1.5 mm away from limbus and from each other. The markings being done, this is a perpendicular marking from the limbus, 1.5 mm away, and the marking being done parallel to the limbus and 1.5 mm from the previous marking. A scleral tunnel is made from one marking to the other marking. Through this small instrument, the 30 gauge needle goes inside from one marking to the other marking, and we penetrate inside the eyeball. As soon as the needle is visualized, it is brought to the main scleral tunnel. The leading haptic, the tip of leading haptic is fed into the tip of the needle, as we can see, and gradually the IOL being inserted inside the eyeball. As the IOL goes inside, the haptic is being pulled out, and as soon as the haptic is visualized, the piece of band is slipped into the haptic and the needle is separated from the haptic. In similar fashion, we go on the other side. And the trailing haptic is fed into the tip of the needle. About 1/4 of the haptic is being inserted into the needle and is brought out on the other side, and the band being slipped into the haptic. centralization of IOL is done by pulling the haptics and by to and fro movements of the haptics. Once the centralization is done, the bands are removed. The post-op cases, we can see a centralized optic in a traumatic mediatic case, and in the case we can see a centralized optic in an undilated pupil. The results, it's a simple, easy and hassle-free technique with minimal bleeding, takes less surgical time, no hypotony, and is done with readily available instruments. To conclude, it's a safe, minimal invasive technique with a very less surgical time and complication-free. Sutureless, so suture-related scleritis is also prevented. Glueless, less astigmatic, faster wound healing, no wound leakage, no dependency on assistant, risk of slippage of haptics back into vitreous cavity is negligible. It's economic. So the take-home message is it's a minimal invasive technique with faster wound healing and is economic too. So say no to engripping forceps, sutures and glue. I have no financial disclosure. Thank you.
Thank you. I would
Good
say
technique.
Very nice.
Yeah, thank you.
Thank you.
Good technique. So we call Dr. Arnav Singh Saroya, please. A rare case of letrozole-induced central serous chorioretinopathy.
Good morning, everyone. My topic is a rare case of letrozole-induced central serous chorioretinopathy. I have no financial disclosures. Introduction. Central serous chorioretinopathy is characterized by buildup of subretinal fluid at the macula caused by abnormalities of the retinal pigment epithelium dysfunction and choroidal circulation. Fluid leaks from the choroidal circulation to hyperpermeable areas of RPE and accumulates in the subretinal space. CSCR predilection is more in men aged 20 to 50 years and occurs more in women at an older age group. Risk factors can be type A personality, Cushing's disease, sleep, corticosteroid use and other drugs, sleep apnea, pregnancy or H. pylori infection. Drug-induced CSCR is a well-established entity. Aromatase inhibitors such as anastrozole, letrozole have been reported to cause CSCR. AIM was to report a rare case of letrozole-induced central serous chorioretinopathy. Case report is as follows. A 65 years old female presented with history of diminution of vision in both eyes since 2 months. BCVA was 2/60 in the right eye and 6/24 in the left eye. Known case of breast carcinoma treated with letrozole. On examination, age-related cataract was present in both eyes. Fundus evaluation showed subretinal fluid at the macula in right eye, while the left eye was normal. SDOCT of the right eye shows SRF at macula, and on fundus fluorescein angiography, ink blot leak suggestive of CSCR was noticed. A diagnosis of letrozole-induced CSCR was thus made. Patient was advised to stop letrozole after consultation with the oncology department. As we can see in the image, on 2 months follow-up, increase in SRF was noted. Thereafter, patient was advised intravitreal injection of ranibizumab 0.4 mg per 0.05 ml, which was given in the right eye. SRF did not resolve even on 1 month follow-up. Patient was advised to have focal laser in the right eye. On 1 month follow-up after the laser, we noticed that there was reduction in the SRF. Discussion. SCRMs like tamoxifen are well known for their ocular side effects like dryness, cataract, crystalline retinopathy, and macular edema. Aromatase inhibitors such as anastrozole, letrozole, and exmestane have increasingly been prescribed to postmenopausal breast cancer patients as an adjuvant endocrine therapy to truncate the tamoxifen-related ocular side effects, which is also commonly used in breast cancer treatment. Letrozole is also commonly being used in infertility treatment. The mechanism is like estrogen receptors have alpha and beta receptors. Estrogen receptors alpha and beta are expressed in RPE, and neurosensory retina and the choroid are involved. So estrogen, which has neuroprotective effect in the retina, is lost by inhibitors of estrogen synthesis, like aromatase inhibitors. Letrozole inhibits estrogen synthesis, which is responsible for angiogenesis and ranibizumab mediated anti-angiogenesis effect. Merilitia et al. Have reported a case of letrozole-induced macular edema treated with intravitreal ranibizumab. The synergistic effects of ranibizumab and aromatase inhibitors in CSCR was not supported in our patient. Sivaranjani et al. Reported a similar case of letrozole-induced CSCR in a postmenopausal patient who did not respond to ranibizumab but responded to focal laser. Further studies about anti-VEGF in aromatase inhibitors induced CSCR may fill the gaps of knowledge about the treatment issues and may ultimately change our approach to treatment. Conclusion: we report a very rare case of letrozole-induced CSCR in a postmenopausal woman who did not respond to ranibizumab but responded to focal laser. To the best of our knowledge, this is the third case report of letrozole-induced CSCR. It may be prudent for oncologists and radiotherapists to have an ophthalmology consultation for their patients on aromatase inhibitors to understand whether this is indeed rare or underreported. Thank you.
Thank you for finding out this cause for CSCR. Good presentation. Thank you very much. Is Dr. Nivesh Gupta there? Yeah, please come on. His topic is non-inferiority of fundus photos using wide field imaging to charting drawings in retinal detachment.
Good morning everyone. I am Dr. Nivesh Gupta from Retina Foundation, Ahmedabad. My talk is on non-inferiority of fundus findings on images taken on wide field imaging system in comparison to charting drawings in eyes having rhegmatogenous retinal detachment. These were the financial disclosure. Breaks in rhegmatogenous detachments are classically documented by fundus charting. The concept of wide field imaging enables us to capture the peripheral areas of the retina. Various existing wide field imaging systems are Optos and Clarus. The Optos ultra wide field imaging system has proved to have high sensitivity and clinical utility for detecting pathology throughout the fundus, including the posterior pole. The image on the left showing has been captured on Optos. The image on the right has been captured on Clarus. Recently introduced Mirante with 163-degree wide field imaging with a single image capture based on scanning laser ophthalmoscopy. Ultra wide field imaging helps us to document peripheral pathologies such as horseshoe tear and lattice degenerations. Purpose of our study to compare the fundus findings using wide field imaging by SLO based imaging objectively with the standard fundus chartings drawn using indirect ophthalmoscopy subjectively in patients having rhegmatogenous detachment. We included 27 eyes of 27 patients. The patients were referred to our tertiary care center from various institutes who were diagnosed to have rhegmatogenous detachment. Step 1, the patient was subjected to a dilated fundus photographic examination done by the retina fellows as a part of our routine screening process. Then step 2, thorough ophthalmoscopic examination was done by senior consultant and his fundus charting were noted. Now then we compare reason of the fundus charting with the wide field photography was done. Now we will see a few examples of the same. Here we see a temporal detachment with macula off. Here we see a horseshoe tear at 2 o'clock. In this case, we see a large subtotal detachment with multiple peripheral break. In this image on the left, we see a horseshoe tear around 4 o'clock Interestingly, a small anterior brake can also be picked up by the machine at around 2 o'clock. We documented our findings in a tabulated form under various headings like extent of detachment, location, number and type of brake, and associated peripheral findings such as buckle effect or cryomark. We found that 26 patients had rhegmatogenous detachment and 1 patient had retinoschisis. All clinical findings between the two were matching equally in our series. Also, we found that detailed findings can be taken up to 15 to 20 minutes while fundus charting, and wide field photography can take only 2 to 5 minutes. In our study, we documented that the extent of retinal detachment through SLO-based wide field imaging with a single image capture. Detachments have been documented well on Optos and Clarus, but to the best of our knowledge, a similar comparison has not been done between the subjective charting and objective wide field imaging. Uzuki et al. Revealed that ultra-wide field fundus imaging has a sensitivity of 97.6% and a specificity of 96.5% for detecting rhegmatogenous detachments. We conclude that SLO-based wide field imaging documentation was found to be non-inferior to the traditional subjective but time-consuming art of fundus charting. In the near future, wide field imaging may become a useful tool for diagnosis, surgical planning, and follow-up rhegmatogenous detachments. Thank you.
Yeah, thank you. Thank you very much. But don't lose your art of making drawings till you get this instrument, which is so costly. Yeah. Your drawings are also very good. Thank you. So with this, we conclude the session. The next session, people are there? Yeah, please take on. Sorry for the delay a little bit. So thank you very much, each one of you. Thank you.